So I just want to take everybody through the different kinds of primary care clinicians and how they are similar and how they are different, because not everybody knows. Family medicine physicians, I'm one of those. Take care of the entire family. We start at, I was trained to do deliveries, and I'm trained to do geriatric care. So I start with pregnant women, or I can start with pregnant women, deliver their babies, and then take care of their babies till they're older than me, pretty old, and help people as they're getting ready to die. About a third of the primary care physicians in the country are family physicians. We see relatively fewer in Rhode Island, and relatively more internists and pediatricians, sort of a culture thing, but as you go west, you tend to see mostly family physicians in those communities. Who knows the difference between an MD and a DO? There actually isn't much, but the truth is, so an MD is a medical doctor and a DO is a doctor of osteopathy. I'm the MD sort. They are different kind of medical school traditions, so that I'm trained mostly to think about how to use medicines, and DOs are trained to think a lot about how to use manipulation, how to do things that feel to me a little bit like chiropractic, only different, to treat musculoskeletal injury. They come out of that manipulative history, and in many ways they're particularly well trained to do primary care because, as I said, 30% of what people in primary care see are back pain and musculoskeletal pain. They can fix it with their hands, and I can fix it by begging the person to go to physical therapy. So my DO colleagues in some ways are better than me at primary care. I am, I've been spending some time with some of those colleagues at educational conferences and learning about how much science they actually bring to these manipulative processes. They have a huge amount of science. They know it inside and out. I know relatively little, so they're important and valuable. There used to be a DO hospital in Rhode Island. Anybody know what it was called? It was the old Cranston General. That was a DO hospital. The closest DO medical school is in Orico, Maine, University of New England, but there are lots of people who come out of that medical school and practice in Rhode Island. Another dirty little secret about the medical side of this is, of the Rhode Islanders who go to medical school, more go to the University of New England than go to Brown. So many of the folks who come from Rhode Island and go to medical school and come back to practice here actually will be DOs, and in my view of the world, that's a good thing. A general internist is somebody who takes care of people 18 and older and tends not to get much involved with gynecologic care. So family docs, we do gynecologic care as well as, hearts and lungs and heart failure and so forth, and hypertension. General internists tend to be more focused on hearts and lungs and high blood pressure, and less focused on gynecologic care. Pediatricians, pretty straightforward. Kids usually up to 18. Pediatricians are particularly important for kids with multiple disabilities because their care is difficult and are really important in working through things like newborns. I'll talk a little later about why newborns are scary and should be scary, and why you gotta pay particular attention when there's a newborn, because there are a couple of things that can happen in the newborn period that don't look like anything and turn out to be potentially devastating. Nurse practitioners are nurses who then go for advanced training, and they come in a couple of stripes. Family nurse practitioners who take care of everybody, pediatric nurse practitioners and adult nurse practitioners. We've got a bunch working with us at Blackstone now, and they are really a real helpful improvement in the primary care workforce. Physician assistants are a whole different training process. You don't have to go to nursing school to become a PA. It's about, I can't remember, it's a year and a half or 2 years after college. And those folks used to have to practice in close proximity and under the supervision of a physician, but that's now less true. So many PAs and many nurse practitioners are practicing essentially on their own or practicing in a big group. We have, I think, 3 PA training programs in Rhode Island now. There's one at Johnson & Wales, and a couple of others. And that means I think we'll be seeing more PAs staying around the state, though as I look at them, it turns out that most of their students are coming from out of Rhode Island and go to practice out of Rhode Island, so I'm not sure how many we can actually see, but it's important to know that they function very much like nurse practitioners who now function very much like primary care physicians. Primary care physicians have 7 years of training, 4 years of medical school, and 3 years of internship and residency. Nurses have 4 years of undergraduate nursing preparation and then a year or 2 of often masters or their nurse practitioner training itself. So the training is a little bit different, but the practice is often very similar. Any questions about that? Anybody thinking about going to PA school or nurse practitioner school? Anybody going to nursing school? It's a good next step for people who've been EMTs. You know, after people go to do paramedics, sometimes the next training step is nursing school or medical school. And it's something I'm a big enthusiast of. I think it's a really important thing that we develop job ladders for people, so that after you've gotten a couple of years working on the street, you know what you're doing, you find the next place to go, because the best doctors are the people who have been on the street and see what it's like to walk into somebody's house in the middle of a cardiac arrest. People who have those skills are people who are going to make great doctors. My guess is you guys all have those skills. So think about moving on. We need your
27 Summit Street.
Now it turns out that primary care handles most of the nation's healthcare needs. This is a famous, very famous slide, and I'll reduce it to a simple idea.
27 Summit Street.
1,000 people in a month, 800 of whom have symptoms. About 300 to 400 seek some sort of care, and 217 will visit a physician's office, and more than half of those will see a primary care physician's office. It turns out that only 13 of that 1,000 will visit the emergency department. 6 will get admitted to the hospital, and less than 1 will get admitted to an academic health center. That observation has caused some of us to scratch our heads a little bit, because it turns out lots of the recommendations we make are made based on that one person who goes to the academic health center. The people who study things don't actually see the entire universe of care. So when you see a recommendation from somebody that looks like it's totally crazy, it's probably because of this bias, which is actually fairly substantial. But the important piece is, of the 3 to 4 to 6 transports a day that are coming out of Central Falls, it's worth knowing that Blackstone's seeing 200 to 300 people a day.
It said you want us to allow
all the people
It's more than 6.
Excuse me?
For the hospital transports?
Yeah,
It's more than 6.
6, 10,
3-year-old
it's actually probably an average of 10 now that I think about it, because it's about 300 a month.
Said you want us to 27.
But
27
but even if it's 10, remember that there's a whole bunch that are also being seen elsewhere, and Blackstone, my guess is, represents, as we look at it, only 60-ish% of the population of the city. A lot of people in the city go to the Oak Family Care Center, or they get their primary care elsewhere. So, when you really look at what's happening in the city, I'll take your number as 10 transports by EMS, probably, I'm guessing, 400, 500 people going to the doctor, 600 people going to the doctor every day. That's the universe that we're swimming in, and the idea is to make that universe coherent.
How many city residents do you have as patients for Blackstone Valley Health?
Right now, it depends on what we're counting as patients, but there were about 7,000 who are enrolled, probably now up to 8,000. And then there are 3,000 to 4,000 a year who use Express Care. So when you put it all together, it's probably 12,000 to 13,000.
And they're using that as your primary care? That's the primary care, that number?
Well, it's closer to 8,000 that's doing primary care from the city.
Yeah.
And we expect that number is going to grow once the neighborhood health stations opens. I suspect most of you who have been through Chestnut Street,
Yeah.
which is little and cramped and doesn't have enough doctors. So when we go to the new neighborhood health station, which is 47,000 square feet, and we'll have space for 10 primary care doctors. 10 primary care doctors, each one takes care of 1,500 to 2,000 patients. Maybe 1,000, but that means we all of a sudden have room for 15 to 20,000 people. So this is all. The ground is going to shift a little bit when the neighborhood health station opens.
And you want to final on that, you want to just find 27 Summit for rescue call.
Nobody wants to sit in that
Roger.
waiting room at Chestnut Street.
Joey.
And there's also a lot of back and forth because there are a bunch of people from Central Falls who use Blackstone on East Avenue in Pawtucket. So, I think the dynamics are going to change in about a month when that health station opens.
Because you also, going to 9 Chestnut, transporting out of there, you also see a lot of Pawtucket residents that are using that as well.
Yeah, it goes back and forth. But my expectation is over time, we're going to see many more people from Central Falls using the neighborhood health station just because, it's there, it'll be open. It'll be, I think, pretty beautiful. Not that beauty matters, but it turns out when you study it, for people under 40, the thing that makes them choose a doctor doesn't have anything to do with the way the doctor functions. It actually has to do with how the office works. So the office will look nice. Maybe people under 40 will use it more. I'm not sure many of us would be excited about going to Chestnut Street the way it looks today, but I think most people, will like the way the new neighborhood health station looks. And, when they finally get the parking lot finished, there'll actually be parking. If you look at, if you've ever been to East Avenue, we're going to go over this later this morning, but there's no parking at East Avenue. So, I think the dynamics are going to change like 100 times for better or for worse. Hopefully for better. Go ahead.
So, you're going to charge $250 roughly per visit. The rescue operates on income that we charge. It's a small portion that we actually collect, say it's $300,000, and we use that for rescue expenses. When somebody looks at their bill and sees that you're charging $250 and we're charging anywhere between $500 and $1,000, how can we justify that?
Well,
Does that make, you know what I'm saying? Like, in the long run, people are gonna catch on and they're gonna say, well, I'm only paying $250 for the care, but I paid $1,000 to get there, a quarter of a mile. How are we gonna justify that?
well, that situation exists today. It's not going to change. That's not changing at all. The way,
And you want to
from a
see
health policy
27 Summit.
what people who think about health policy want to happen is they want more people to use primary care because the outcomes are better.
I'm wondering, like, what is our
there's no
effect?
treatment.
Like, what's gonna affect us? Are we gonna end up collecting less because people are just gonna say, I'm not gonna pay this bill now, I'm gonna pay this $250 and be done with it?
I can't tell you what people are going to do. But, the trajectory over time is, and this is not just here, the trajectory over time in Central Falls, in the state, and in the nation, is for us to use less emergency care, less hospitals.
That affects
And
us
more primary
really
That
badly.
directly affects
Well,
us.
you know, but the
That's our
idea
job.
is to take,
It's our job.
is to take that impact and get you guys doing more treatment in the field, get you guys working as part of the healthcare team, doing outreach to folks elsewhere, to different kinds of folks around. And it's gonna happen all over the place, it's not just here.
Yeah, but all of it isn't affecting our daily life.
Yeah, I hear you.
This is, and that's a big issue.
I hear you, but at the same time, can we as a nation continue to spend what we're spending on healthcare? The answer is probably not. So, there are gonna be changes. The rough estimate is that 50% of hospitals will eventually go away, because we probably didn't need them. That's what happened in a bunch of other countries. When you start building up the primary care piece, what happens is the cost to the place in the nation goes down, the health outcomes increase, and everybody in society does better as a result. Remember, our collective job. I'm sorry?
Exactly what it is.
Well, no, our collective job is to improve the outcomes.
Socialism. It comes down to it, it really is.
I don't think this is the place or time for that argument.
I'm just concerned about us as a whole, and I'm just trying to think of issues that could come up, that's all. It's not an argument, it's just a point that I think.
Yeah, I mean, all government spending on health might be considered socialism, because the government's spending money on health.
Now it is, yeah.
So, most of, one might argue that Central Falls providing EMS services is socialism, because it's the government providing a service. But I don't think that gets us anyplace. At the end of the day, the challenge is to figure out how we together do the best job we can taking care of the population we're supposed to serve, and making Central Falls and Rhode Island a healthier place.
I understand it, and that's noble, but I'm still concerned about our jobs here too,
I hear you. But my hope and expectation is that as we get better at this, we get you guys working with us as part of the healthcare team, knocking on doors and, sort of doing some treatment in the field, helping take. I'm sorry?
Home visits?
Sorry?
Home visits?
Well, sort of, their treatment in the field, some of the mobile integrated care stuff around the country is taking paramedics into, responding to emergency calls and getting the person treated in the field instead of being transported. That's kind of the direction that EMS is going nationally.
But we're gonna do more on scene, and the people that don't pay already are just not gonna pay, and we're gonna be doing more. If,
Like,
I
mean, it's.
I know this is a hypothetical,
Yeah.
if everything works out 2 years down the road, but it seems a lot of hypotheticals.
So another truck is.
And more work for us. And I don't know where our money's gonna come from, that extra money that's gonna help us in the field. I don't think this puts extra guys on the job, I don't think this helps us in any way, I mean, hopefully it does. Maybe you have a different plan that we don't know about, but right now, it's tough to.
I hear you. New stuff is new stuff, but I think at the end of the day, we're gonna all end up being a little more satisfied with what we do every day and have the resources we need to do it well, because we're not wasting resources on care that may not be necessary, which is where we're at now. We compare us to other countries. We piss money away, left, right, up, and down. And it limits what the economy can do. So Rhode Island's economy isn't so great, in part because we spend too much money on healthcare. And it means that, in the United States, our life expectancy is shorter, and most of our health outcomes are worse. We spend twice as much as any other country in the world, and our health outcomes rank us like 50th in the world. That is something I'm particularly proud of. I think it's something we could do better.
What is the long term, where's the benefit for us? Because if we function on this, community healthcare initiative, where we're sending people out and doing diagnostic and that's taking manpower away from the fire department, which also serves the community. And if we have someone, diagnosing, we have our rescue out diagnosing, we roll to a house fire. I mean, not of your concern, the fire side is completely different than the healthcare, but you're taking away from the manning. Do we have a project where we're hiring more people, which are gonna be healthcare initiative individuals? Are we sending them to medic school? Like, where's that portion of this coming from?
The idea is to do this over time in a balanced way, so that, we take it step by step, do a little piece, see how it works, see what its impact is, and adjust where we need to. We've done some talking about trying to make sure that there are opportunities for folks on this squad to go to paramedic school and get loan repayment for doing that. I'd like to see more people become paramedics in anticipation of that. Everything else at this point is speculation. The idea is to toe in a little bit and sort of see how we do with a little bit of this mobile integrated care, and then see what the impacts are and adjust as we need to.
Long term, is there an idea of like, they're functioning rescue out of Blackstone Valley Health, like a life pack type of truck? Or is the Blackstone Valley Healthcare truck always gonna be Central Falls Fire?
Well, I wouldn't characterize it either way. As far as I see, the Central Falls Fire is always going to be Central Falls Fire. Blackstone Valley is always going to be the neighborhood health station. And the challenge and opportunity is we just learn to work together. So, we talk the same language, we take care of the same people, and we do it in the same way.
You're saying Central Falls Fire, that's true. Central Falls Fire will always be Central Falls Fire. Where Central Falls EMS will always be Central Falls EMS.
I meant EMS as part of Central Falls Fire. I don't see any substantial difference over time. Just sort of more collaboration, more partnership, and more effectiveness. We all can just do better than we've been doing. Not that we don't do a great job every day, but the impact of what we do could be a little bit, and we could just be more effective. You gotta kind of look at what we actually, at the end product of what we do, not just what we do every day. And the end product of what we do has some room for improvement. That's what this is designed to begin to get at. It's just the beginning of it. So, ready for me to go on or more questions?
So it's Pawtucket and then the location here, right? That's it?
No, just Central Falls.
Oh, okay. So
This
well,
is,
we're affiliated now with the other one, right?
well, Blackstone Valley has 3 different major locations. 1 in Central Falls and 2 in Pawtucket.
Okay. So this is gonna, well, once this new building goes, then we're on our own?
No. Blackstone.
It's still gonna be affiliated with it, right?
Still part
Okay,
of
alright.
Blackstone.
Alright.
And, we will see what happens in Pawtucket over years.
Where's the two ones?
One's on East Avenue, right around the corner from Slater Mill. One's down North Main Street, near LA Fitness.
Okay.
Those are the big ones. There's some other little ones floating around. We have a little bit of space in the high school. We run a school-based health center there. We've been doing it for a couple of years. So when somebody asks me how many people are enrolled, we've got basically all the kids in the high school.
Right, gotcha.
So a little bit here, a little bit there, and the new neighborhood health station is going to be big.
Is Kentucky Fire transporting to the Kentucky locations?
I don't know we haven't worked with Kentucky Fire yet.
Is that it works with them, or is it,
Sorry?
are they gonna be doing that in the future, or?
I can't speak for them. The architecture at those other 2 sites is nowhere near the sophisticated architecture that we have in Central Falls. So we're gonna be way better set up to take care of people in Central Falls than folks are being set up to take care of Pawtucket. I have some hope that over years, we will find a way to open some neighborhood health stations in Pawtucket. So we'll duplicate that process, but that's hope, not any plan.
What do you say
So
years?
please don't go tell the
5
mayor.
years, 10 year, 15, like,
No,
no projection?
no projection, nobody has to tell the mayor of Pawtucket that I said that was gonna happen, because I don't know that that's gonna
Fire
happen.
department's still talking to them anyway, so.
Yeah, yeah, I mean, we all kind of talk to each other, so there are kind of no secrets that I think it's a good idea.
No.
I think I thought it was a way to replace Memorial, is just to build 5 of those, but, there's no money and no plan, that's.
Now, for our community, like where we go in the community, is that like 5 years, like what, how near is that?
Oh, that, I don't have a clue. The idea was to take this in a little bite, see if we could get this done, learn how to work together, and then see where we go from there. Begin to think about how we get more paramedics here, and begin to grow it in that direction gently, but take it one step at a time. Other questions? Larry?
I want to say that I hear the concerns that are being raised, and they're completely valid, especially the ones around financing and what does that mean for the future of the fire department. Those are concerns that you should have, and that other departments that are implementing this have had. There's different ways to finance this. The discussions around accountable entities, Dr. Fine referenced earlier, they're looking at creative ways of partnering with the right service delivery partners, and looking at how savings in the system can be redistributed more efficiently to deliver services. And also, there are models where hospitals that are not admitting patients that are being stabilized and don't belong in the hospital, those savings are being shared with EMS providers and fire departments, so that's another model. So there's a lot of potential discussion around how global integrated healthcare is financed, how you are financed, how your equipment and manpower needs are supported in this partnership. So I don't have the answer, I don't know what's in store, but it's absolutely the right questions to be asking.
And conversely, healthcare's changing, and healthcare financing is changing. Just isn't going to stay the same. There's no way in the world it's going to stay the way it is just because of the overall expense. And the opportunity, as I see it, is for us to learn to work together and figure out how to change it the right way instead of changing it the wrong way. And we have a great opportunity.
I'd just like to say that I understand what you're saying and what you're trying to do and everything. But with this department, we really don't even have an EMS full-time service. With cross-manning our trucks, you're talking paramedics. One day the guy could be on the truck, the next day the paramedic's not on there. So I understand what the guys are concerned with is that was never our job. At one time, the police were taking care of EMS. This is something to be put on to us. And you're talking other departments in other locations in other states, but they have permanent EMS. We're so small, we don't even have permanent EMS, but you're talking like you want guys to become paramedics, that they'll never be able to use their skills, because if we're out on a fire or something, we don't even have an EMS truck available. We're calling in a mutual aid truck, and they're not gonna transport to your facility even though they're coming into the city. I can understand everybody's concern. I can understand where you're coming from and insight. The biggest problem is we can't teach common sense to these people. You have to be born with it. These people will call you for anything because they've been trained by doctors and by the government to call 911. Because if you call your doctor's office right now and they tell you, if this is an emergency or if this is after hours, call 911. We're teaching them how to do this. Now you want to unteach them what you've taught them for the last 20 years.
I think that captures it. We got a lot of work to do to change,
And the hard part is you can't teach old dog new tricks.
but you can create a world in which it makes more sense to do it a different way.
You're not gonna change the way these people have been created. I've lived in this city all my life. I've worked here for 37 years. I've seen the changes that the government and the doctors have made, and it's not for the good, it's for the worse. Because at one time, if you called me for an EMS, I was allowed to tell you that this is not an EMS, this is not an emergency. You gotta call another means of transportation, or go to your own doctor, or get in your car and go. But we've trained these people like, no, you have to take me to the hospital, and I'm telling you what hospital I'm going to. And that's in the state protocol. They have that right.
And we are gradually gonna try to hammer away at it and change it. I mean, this whole process started you know, like I said, 4, 5, 6 years ago. And we have been working inch by inch to try to figure out what to change and how to change. You know, that we got this, you know, that we got a we got this whole process. We had to make some change in regulation to make it happen. So we got that change in regulation done. And these are doable things, but like you said,
Not
it's
this
not-
department,
it's
it's
not
so
gonna-
small of a department, like you said, we don't even have a full-time rescue. We have it at times where we don't even have a rescue available because our trucks are broken down. We have to borrow trucks from other facilities, and you want us to do more with the vehicles we have or we don't have? Here we go with the common sense again.
Yeah, I'm afraid I don't think we're gonna have to do more. I think we have the opportunity to do it better. And that better.
But we're asking us to do better with equipment we don't have. A vehicle is the first thing to get us there.
Right.
The training, we can all be trained, but if I can't get there, I'm gonna do of no value to anybody.
Let's go forward, and as we talk, sort of see if we can discover some of those opportunities to just do it better. Because that's the art here, is to not keep doing what we've always done because we've always done it, but to figure out how we can do it better than we've done it before. And if it means changing people's attitudes, if it means changing regulation, then we need to understand that and put those changes into place. They are doable things. You know, we got here,
Oh yeah, we put us there.
so if we got ourselves here, then we can get ourselves someplace else.
And it's not my lifetime.
Well,
I intend to live to be over 100.
all right, I was just checking. All right,
You
let's
know,
go ahead.
we're hearing a lot of, you know, we want to build this, we want to create this, we want to build this. But tell me why it benefits the fire department and the EMS. Like, you know, I understand respectively that you're saying, oh, we're going to build this, but how does it positively affect us in our daily operation?
I think the way it's gonna positively affect you in your daily operation is to make it so there are fewer things that didn't need to happen, that you do, so you have the time, and ability to focus on what we really need you for.
Our protocols dictate what we do. We have a book that we have to go by, so we're going to be following our protocol regardless.
Well,
You know,
but I think you're gonna see that there are gonna be some opportunities, and we haven't even talked about the draft protocol we're gonna use for this. There are gonna be some opportunities that make it so you don't have to drive, you don't have to transport out of the city, you can transport right inside the city and be, you know, back to being ready for the next thing quite quickly.
our transport's a reasonably short period anyway.
They're getting long now.
They're getting longer than what we were used to,
Right.
but
This gives us the opportunity to sort of lighten some of the load, which is what we're trying to do, and make the load most appropriate. Because there are things we really need you guys for. But you all know that when you walk into certain situations, you didn't need to be there. And that's, as I understand it, reasonably frustrating. And, you know, you never want to be out transporting somebody with problem X out of the city when there's an MI, and then that created more transport time.
That happens so frequently.
Well,
It
yeah,
happens multiple times on a day.
Yeah, if we're sitting at somebody's house though, diagnosing somebody for whatever to bring to your facility and something else happens, what's the difference?
well, I
If we
think
could have
what,
transported and been back in the city in a half hour instead of wasting a half hour on scene.
well, I don't think you're gonna, I mean, why don't you wait and see what the protocol is? The protocol is quite short. And that's why I wanted Dr. Sam to be here. Essentially, there's gonna be a clinician who's gonna carry a hot phone, and you're gonna be able to get right in right away, you know, and have a conversation about what you're seeing.
And how many transports from your facility do you think we're gonna do each year to a real hospital?
I don't know, I don't think we have a way to know that just yet. You know, obviously that number.
But I know we do it now from
Right.
when it's existing.
And you would imagine that that number is probably going to increase as the volume increases. You know, if we go to seeing, you know, 75 people a day in Central Falls. to
So
see-
the person with the MI is still being waiting for another mutual aid truck because we're transporting somebody that we transported originally to a facility that couldn't treat the treatment that they needed.
Well, but I think what we're gonna do is, you know, sort of balance things a little better, make it so that you're free to do that transportation of the MI, and make it so that you're not stuck doing stuff that you didn't need to do. I'm trying to make it so that we take best advantage of the skills that you have, which we really need. And those aren't going away. Remember, you know, the one interesting thing is we got 20,000 people. And so we have a set amount of work that's going to stay pretty stable over time. Our job is to figure out how to address that work with most efficiency and most sophistication. So, you know, when we need EMS, we bring EMS full guns. When we don't need EMS, hopefully that's work you guys don't have to do. Any more? Let's go on. And I'm going to say we're going to take, we've been here about an hour and a half, so let's try to take a break in about 15 minutes. So, back to what primary care is and how it works. So what problems do primary care clinicians treat? A lot of upper respiratory infections, a lot of back pain, a lot of belly pain, a lot of urinary tract infections, a lot of urinary tract infections, a lot of cough, a lot of fever, a lot of nausea and vomiting, a lot of diarrhea, and a lot of rashes. And we're going to have people coming to talk about all those things and how we do it, so you get a feel for what it is we do and how we approach it. And other kinds of things, headache, sprain, allergies, sexually transmitted disease, vaginal discharge, alcohol and other substance abuse, neck pain, dizziness, anxiety, sore throat, and chest pain. That's our daily work. But also the long-term management of diabetes, heart disease, high blood pressure, asthma, COPD, high cholesterol, kidney stones, gout, arthritis, hepatitis, and HIV. We're involved with all that stuff and do it every single day. We do yearly physicals. We work to keep people up to date on vaccinations. And actually, the vaccination question provides an interesting opportunity to get at the question before. So anybody know how many people died of influenza and influenza-related illnesses in the United States last year?
Well, it's a couple different numbers. A lot of people say they didn't die exactly from the flu.
That's why it's influenza and influenza-related.
Okay, they didn't test positive for the flu, the big number they had.
It's a standard measure of that kind of stuff every year.
What's the number, Sean?
It's a fair question, but you know, if you take the whole bunch together, anybody know what the whole bunch is last year?
27,000.
80,000. On an average year, your numbers are the best. You're pretty good at an average year is usually 27,000, 30,000, something like that. So we bumped up 50,000. Now, anybody know what happened to people getting the flu shot last year?
Died.
Yeah, it died. Basically, it dropped from 44% or 43% to 37%.
That's good.
Now, nobody knows for sure how good the flu shot is, but most of us think it's better than nothing. And so most of us think there's probably some relationship between the drop in number of people who got flu shots and the number of people who got and died of the flu or flu-related illness, which is a more accurate way to say it. It's a real thing. So it's the job of primary care folks to get people vaccinated. If we do a better job getting people vaccinated, if we can take it from 37% to 75 or 80%, then everybody's best guess is there are going to be a whole lot fewer people getting sick in the winter and a whole lot fewer flu-related and flu-associated disease-related transports. And that's basically the way this whole thing works. You know, you do it well on one side, you actually get to protect your resources on the other side, so you can deploy them for what really matters. Anyway, so, and then primary care folks work to prevent diabetes, heart disease, high blood pressure, stroke, and cancer, mostly by telling people to exercise and lose weight, which is how you prevent those things, by and large, and to quit smoking. And so we have all sorts of people now, and we're going to get more people who work on helping people change their diets and start to exercise. And actually, we have a great partnership with the Department of Parks and Rec and others to try to provide people ways of getting exercise. One of the things that came out of all this stuff over the last couple of years I don't know if you guys know this, but there's a bus that goes 3 times a week from Central Falls to the Y in Pawtucket. That's free and lets anybody in Central Falls use that Y for free to try to get more people exercising, to prevent diabetes and heart disease and all
I was
that.
gonna walk there, it's less than a walk.
But that would actually be better, but, you know, you gotta do what you do. So primary care folks fill out a lot of forms, and are available 24 hours a day, 7 days a week. There's always somebody on call about stuff. So, you know, what we try to encourage people to do is not, you know, sort of, if you're not feeling well, call 911. We try to encourage people to, if you're not feeling well, to call us. And one of our docs on call picks up the call and works out what it is people should do. And most of the time, that's not call 911. Most of the time, it's do something else.
That's decreasing our call volume considerably, right?
That's the idea.
That,
To make sure that,
I don't know if that's necessarily a good thing.
Suicide at 5? Is that
well, you
We're already
know,
at 7 guys, then they're gonna cut us 2 more guys now because we're saving rescue runs and.
They're gonna say, oh, your numbers have decreased from year to year
That's
significantly.
Do you feel we need a
You know,
second rescue in the city?
I don't think this is the place or time for that kind of discussion. I haven't seen the numbers one way or another that says that, but I think the aim is to make sure that people have the appropriate use of healthcare. So what's the battle rhythm of primary care? Most primary care clinicians see patients from 8 in the morning till 4 in the afternoon. Many have extended and weekend hours, and that's what we're trying to move in. Most primary care clinicians see people by appointment and see 2 to 4 patients an hour, to give you a feel for that. And most leave a number of appointments open for people who are sick that day. So people who are sick that day are people who we try to see that day. Most primary care people take care of between 1,000 and 2,000 patients, which is actually a pretty big number when you've got what everybody needs. And if you remember, you know, that square diagram of 1,000 people, that's about the workload of one primary care person, or maybe a little more than that. Most primary care clinicians now spend a quarter of their time answering phone calls, filling out forms, and refilling prescriptions. And most work at home after hours on paperwork, usually 2 or 3 hours a night. So it's hard work, and they work hard at it, and they stay with it.
Roger, we'll be in service out here.
We tell people the best way to talk to a primary care clinician is to make an appointment, see that person face to face. It's possible but difficult to contact most primary care clinicians by phone. It is a relatively hard thing to pick up the phone and expect to talk to your own personal physician right away. What most of us do is, you know, ask people to leave messages, and we try to get somebody to call them back. But that isn't perfect, and we're going to get a look at that at 11:30 as we walk through the call system, the phone bank at Blackstone on East Avenue, because that's where that phone bank is. And managing extra demand is difficult. There aren't really good rules for what happens when 10 more people want to be seen and there are no more appointments left. And that's where Express Care comes in. The unusual thing about the neighborhood health station is it has this robust Express Care component. So that, you know, for many primary care practices, if they're full, you're stuck. For Blackstone, if your doctor is full, then we'll get you seen at Express Care, and that works pretty well. It functions kind of like mutual aid for primary care clinicians. So primary care can take care of so many problems. Why do we need emergency departments? Emergency departments are critical resources to care for people with life or limb-threatening illnesses or injuries. Emergency departments provide quick access to intensive care, to surgical intervention, and other life-saving treatment, none of which is available in primary care practices, community health centers, and primary care is much less valuable without emergency medicine backup. This is a partnership. Primary care folks take the load off emergency departments. The emergency departments need to be there when we need them. Everybody together as one integrated healthcare system. And the idea is to build on that integration. It's always been like that. The idea is to understand that, build on it, and make it stronger. As I said, express care, primary care clinicians available without appointment. It's not the same as regular primary care. You see a different person each time. Most visits take care of only one problem. The waiting times may vary with demand, so there's certain times a day when there's not much waiting time, there's certain times a day when the waiting time is overwhelming. And what we do is focus on treatment in express care, not on prevention, and then we work hard to arrange follow-up with the primary care clinician all the time. So it's first contact, not continuous, not comprehensive, not coordinated, but it is patient-centered. And why is that important in Central Falls? That's where we can take care of people who are sick today, who don't need hospital level care, who don't want to wait for an appointment with the regular primary care clinician. So we get people seen the same day they're sick. So altogether, primary care clinicians can care for much of what people call EMS in Central Falls for. Express care is a good way to use primary care when a person doesn't have an appointment. The new neighborhood health station gives us an opportunity we didn't have before, and if we can figure out how to do this right, we save the state as much as $4 million a year, money that can and should be spent on education, housing, community development. And that's it for this session. Why don't we take a break and try to get back here right around 10 o'clock. Thank you all.